अस्सलाम वालेकुम। आवाज आ रही है आपको? साहिब।
वालेकुम सलाम। जी जी, आवाज़ आ रही है आपकी।
ओके, थैंक यू।
हेलो। आवाज़ आ रही है आपको?
जी जी, बिल्कुल मुझे आवाज आ रही है, थैंक यू।
अच्छा, ये मैं जो है वो आपको होस्ट कर दूंगा। असल में मैं ऑफिस में ही हूँ और यहाँ पे शटडाउन
ठीक
हुआ
है।
हुआ है। तो यहाँ पे बिल्कुल
ओके।
पावर वावर कुछ भी नहीं है, इंटरनेट वगैरह कुछ भी नहीं चल रहा है। ठीक है।
ठीक है। ठीक है।
मैं थोड़ी
ठीक
देर
है।
में आपको होस्ट कर देता हूँ। ओके, मोबाइल से ही लॉग इन हो। ओके ओके।
ठीक।
अस्सलाम वालेकुम वकास, आवाज़ आ रही?
जी सर, बिल्कुल आवाज आ रही है।
ओके। और मैं अभी स्क्रीन शेयर करता हूँ तो वो भी मुझे बता देना फिर, ठीक है?
जी सर। जी सर।
स्क्रीन शेयर हो रही है।
जी सर, बिल्कुल हो रही है।
और ये मैंने जूम कर दिया है प्रेजेंटेशन, तो नज़र आ रही है?
जी बिल्कुल, स्लाइड मोड पे हो गई जी।
हाँ स्लाइड, मतलब मैंने उसको स्लाइड शो पे लगा दिया ना, तो आ रही है ना?
जी। जी बिल्कुल सर, आ रही
ओके, ठीक है। अच्छा, आज कोऑर्डिनेट किसने करना है?
है। डॉक्टर अस्मा। और उन्होंने बोला अगर वो बिजी होंगी तो फिर डॉक्टर आजहर को रिक्वेस्ट करनी होगी।
ओके, सही है। अच्छा, ये ओके। वकास, आवाज़ सही, क्योंकि मैंने माइक नहीं लगाया हुआ, मैं लैपटॉप के ही माइक से बात कर रहा हूँ, तो सही आ रही है ना? उसमें कोई
जी
इशू
सर,
तो
बिल्कुल
नहीं?
सही आ रही है। नहीं,
बस सही।
बिल्कुल सही आ रही
ठीक है, डन डन।
अस्सलाम वालेकुम, क्या हाल है सोहेब?
अल्लाह का शुक्र सर, बिल्कुल ठीक ठाक।
आज सॉकर की छुट्टी की है?
नहीं नहीं, आज तो कैंसिल हो गया ना सर।
अच्छा, सही
हाँ,
सही सही।
वो अपना गर्मी की वजह से।
ओह, ओके। अच्छा,
हम्म।
कैलोरीज बर्न होनी थी यार। अच्छा, ये तो चलना चाहिए थे।
नहीं, वो
स-
एक्चुअली क्या कहते हैं, डॉक्टर फजल मिले थे मुझे, केस करने के लिए आए थे, तो तब बता रहे थे कि आज। और फिर डॉक्टर सौलत भी, वो थोड़े आए ना हज से, तो ज़रा डाउन थे, वो इस वजह
अच्छा,
से।
सही 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 सही। बस अगले 2 मिनट बाद जो है मैं इंट्रो देता हूँ। मैं वैसे कहा था इसका टाइम ड्यूरेशन ज्यादा ना हो, तो इंट्रोडक्शन के लिए मुझे हाफ एन आवर चाहिए कम से कम।
कोई हो सर, खुदा के वास्ते मेहरबानी करें आप। इतना लंबा इंट्रोडक्शन नहीं है, बस प्रेजेंटेशन को मैं इंशाल्लाह कोशिश करूंगा टाइम पे बस खत्म करें।
यार, हर हर अजीम बंदा यही कहता है।
हम्म। हम 8:05 तक वेट करते हैं ना, 8:05 पे फिर से स्टार्ट कर देते हैं।
मैं उससे पहले इंट्रो वगैरह दूंगा ना। वो चलते चलते 8:05 हो जाएंगे।
ठीक है
टेंशन
सर,
नहीं
डन।
लो।
सही।
सही, फ्लाइट विजिबल है।
और
और
मूव,
ठीक है।
सर मूव हो रही है ना?
हाँ हाँ, मूव हो रही है।
बस सही।
इसमें एक्चुअली मैं देख नहीं पा रहा हूँ कि हमारे पास अभी कितने लोगों ने ज्वाइन किया है। नॉट श्योर।
सर ये 12 हैं अभी पार्टिसिपेंट्स ना।
ओके, सही। एवरीवन कैन हियर मी? हेलो।
जी से
ओके।
बिल्कुल आवाज आ रही है।
अस्सलाम वालेकुम एंड गुड इवनिंग on the behalf of PSA Karachi. Um, on this hot and humid evening, we have a cool breeze in the form of Dr. Sohaib. He needs no introduction. I'm sure everyone from the anesthesia knows him very well. He's a very much interested in education. He's always remains a part of workshops. He conducted a number of workshops, and I very often I say to him that he is the most important ingredient of every workshop that we do in anesthesia or in critical care. Okay, so Dr. Sohaib did his FCPS in anesthesiology primarily, and he's the first candidate from the Karachi. Please turn off your microphone. So he's the first candidate from the Karachi who did his critical care FCPS with the anesthesia background. So I welcome Dr. Sohaib, and he will talk about a very important topic, that is the current fluid controversies. There are a few instructions for the attendees. I will request all the attendees to please turn off your microphone. If you have any question, you can write it in the chat box and you can raise your hand, and that would be answered. And at the end of the this talk, I will request all the participants to fill in the feedback form to get the certificate. So without wasting any time, I would request Dr. Sohaib to please start your talk.
Thank you, sir, for such a kind introduction, or what I feel say. Thank you so much. The topic assigned to me, so we are like doing a ICU series of lectures online. So the topic which I chose was like the current fluid controversies in ICU. So in like couple of next like 40 to 45 minutes, I will try to highlight the controversies which are like pertaining to the fluid management in an ICU. And it's like I will not touch like the perioperative part. It's mainly the critical care area, but I will like give a little bit of a glimpses of that as well, of the intraoperative or perioperative management of fluid as well. Uh, uh, so to start with, no disclosure of this is a disclosure statement. I have no financial relationship or like a financial benefit of giving this talk. So the outline of presentation will be the first of all I will share some of the definitions which needs a little bit of clarity. We usually say that the patient is having a fluid overload. What we mean by fluid overload, what means by fluid challenge or fluid bolus, what's mean by balanced fluids. So we will talk a little bit about that. The second part will be the debate, always colloids versus crystalloids. Then a couple of slides on normal. I have mentioned in the bracket the abnormal 0.9% saline versus the balanced crystalloid solutions. Then the albumin, what is the role of albumin for resuscitation, and where we stand in terms of using albumin for resuscitation. Then liberal versus conservative fluid for sepsis. So it's also a topic of a recent interest. People are doing a lot of things for that. And in the end, I will discuss like 4Ds of fluid management. This is one of the topic which the International Fluid Academy usually tells in every of their conferences, which they do in an anesthesia or like do in an ICU. So to start with definitions, I have taken these definitions from this book, which is published recently, The Rational Use of Intravenous Fluids in Critically Ill Patients. This is written by Manu Malbrain, one of the like the founding members of International Fluid Academy, and he is like very much known of this International Fluid Academy. So Manu Malbrain and all the other co-authors like written this book, which almost covers everything, and they try to highlight which is the best way to give the intravenous fluids in critically ill patient. To start with, like what means by daily fluid balance. So daily fluid balance is the difference between all fluids given to a patient during a 24-hour period and combined output. So we have to calculate the input and the output. Then what is the cumulative fluid balance? The cumulative fluid balance is the amount of fluid accumulated by calculating the sum of daily fluid balances over a set period of time. So we usually in ICU we see the 24 hours balance, that is called the daily fluid balance, and then we see the cumulative fluid balance. Like if the patient is staying for more for a week, then we will calculate what is the cumulative fluid balance. Fluid bolus. A fluid bolus is a rapid infusion of a fluid over a short period of time. And in clinical practice, a fluid bolus is usually given to correct hypovolemia, hypotension, or inadequate blood flow or impaired microcirculatory perfusion. A fluid bolus typically includes the infusion of 4 to 6 ml per kg of IV fluid over a maximum of 10 to 20 minutes. Now, what is the fluid overload? So, we should calculate the fluid overload like dividing the cumulative fluid balance in liters by patient's baseline body weight and multiplying by 100% defines the percentage of fluid accumulation. So the cumulative fluid balance, which I've already told you, that it is the fluid balance over a set period of time. Either we should take a 5 days, 4 days, 3 days, or like a 1 week. And then we calculate the cumulative fluid balance in liters by patient's baseline body weight and multiplying by 100%, define the percentage. So we will say that the patient is having a fluid overload as a 10% of fluid accumulation. So why we have chosen the 10% fluid accumulation? Like most of the studies have shown that the more than 10% of a fluid accumulation is associated with worse outcome. So that's why we call it, if the patient is having a fluid overload, if he is having a more than 10% fluid accumulation. Now, what is fluid responsiveness? Fluid responsiveness indicates a condition in which a patient will respond to a fluid administration by a significant increase in stroke volume or a cardiac output or their surrogate. And we usually define it as like this book defines it as like the 15% increase in this, like the cardiac output or like the baseline stroke volume is used for this definition of fluid responsiveness. Interestingly, I have I want to share this definition because like how we define the fluid challenge. So there was one study which is called as Phoenix study, which was conducted in 2015. Like they have conducted a survey all over the important ICUs in the world, and they made a conclusion that the current practice and evaluation of fluid challenge in critically ill patients are highly variable. So prediction of fluid responsiveness is not used routinely. Safety limits are rarely used, and information from previous failed fluid challenges is not always taken into account. So there was not a single criteria the people were using for using the fluid challenge. So somebody was giving, like I have already defined that they have defined it like a 4 ml per kg over a 5 to 10 minutes time. But like when they conducted a survey, so the people are using different practices for the fluid challenge. This is one of them, again, an article, which is like a one of an editorial written recently. And this is written by like a John Lewis Vincent and Daniel D. Becker, one of the pioneers of like physiological, applied physiology in ICU and the fluid masters. So they have also written in there this editorial that I have already highlighted, that somebody has used a 1 liter of saline over a 5 to 10 minutes and resulted in an increase in cardiac index. One has used a 4 ml per kg, and some people have said that they use this fluid challenge or like fluid bolus given over a 15 to 20 to 30 minutes. And they argue in this that 20 to 30-minute time duration is like quite a long duration of time, and there are a couple of things that can happen during that time which can make our result earnest. Like we don't know that this fluid challenge is producing the desired response, like increase in the cardiac output or the stroke volume. So that the period of fluid challenge should be short. Then they have another definition of mini fluid challenge, that they give the 100 ml colloid, because in all the above, like they are given 4 ml per kg, that was the crystalloid. So one thought process is that you should give a mini fluid challenge of 100 ml fluid over 1 minute and then see the proposed outcome. They say that in their editorial that it is very fair that to monitor the cardiac output response according to the fluid challenge is not make a difference if the operator is expert, and what we are using to monitor the cardiac output response, like either we are using the pulse pressure variation or either we are a pico or litco for the cardiac output monitor. So it doesn't matter. the matter is like the how we are giving the fluid challenge and what is the duration. So they say that it should be limited duration of 5 to 10 minutes, and we should give a 4 ml per kg. Like a 70 kg person will be getting like a 280 ml or around 300 ml fluid over 5 to 10 minutes, and we see the response. There is one thing like there is a mnemonic known as troll. So troll means what is the type of fluid we are using for a fluid challenge. Either it should be a crystalloid or colloid, balanced versus unbalanced. What should be the rate? It's 4 ml per kg over 5 to 10 minutes. What should be the objective? Normalization of macro arterial pressure or heart rate, or microcirculation, either we are using it. And what should be the limits? Like either it should be the increased CVP, or either it should be the extravascular lung water index, like these things. So this, when we are giving a fluid challenge, so we should make sure we should label what should be the type, what should be the rate, what should be the objective, and what should be the limits. So now we move to what constitutes the balanced solutions. We always say that balanced solutions are good, balanced solutions are should be given to the patient. So what are the balanced solutions? An intravenous crystalloid fluid that contains an electrolyte composition similar to normal plasma. So we usually say that ringer lactate is a balanced solution because all the constituents in ringer lactate are comparable to plasma. But recently, the fluids with a low chloride content are also labeled as balanced solutions. And the balanced solutions are otherwise categorized with a strong ion difference that is close to the plasma, that is 24 to 29 millicurie per liter, causing a minimal effect on acid-base equilibrium. I'm not going into the detail of strong ion difference. It is also actually a steward approach for the acid-base analysis. So one of the method to categorize the balanced solutions are that the ones which have a strong ion difference very close to the plasma. So they are called as like balanced solutions. Or IV fluid containing normal or subnormal chloride content that is less than 110 millicurie per liter, they are called as balanced solutions. So now we move to the first part of our presentation, that the fluids, crystalloids or colloid. So the crystalloid and colloid debate will likely continue indefinitely. I think so, because if you start searching the literature way back, like in 1980s, from there till now, we are still like like after 2 to 3 years, we usually receive some randomized controlled trial and a big studies which show that crystalloids are better or colloids are better. Colloids are not getting any problem to the patient, so we can give colloid. So I will like show you the literature and then till now where we stand. In practice, crystalloids is generally preferred because it is cheaper and more readily available. There is some role of albumin, and there is less favorable evidence of feta starches and gelatins. So there was like one large Cochrane study which was done in 2018, and that was like colloids versus crystalloids for fluid resuscitation in critically ill patients. So now the couple of slides are evidences against starches. So this Cochrane study actually included 69 studies and with more than 30,000 participants. And there it showed that there is a moderate certainty of evidence that starches slightly increases the risk for blood transfusion and renal replacement therapy. Then another trial that is called a chest trial, and there was 7,000 patients, and this paper was published in like New England Journal of Medicine, which also compare hydroxyethyl starches or saline for fluid resuscitation in intensive care. And there was no significant difference in the 90-day mortality between the patient resuscitated with hydroxyethyl starches or saline. However, patients who received resuscitation with hydroxyethyl starches were treated with renal replacement therapy, like more of an increased renal replacement therapy was done in that patients. So this trial also like against the hydroxyethyl starches or colloids for resuscitation. Then there was an again, this is like a little bit of an older study done in 2013, and this was also like Cochrane database, which compares that hydroxyethyl starches versus other fluid therapies and effects on kidney function. They also suggested that there is increased risk of like renal replacement therapy in a patient who received the hydroxyethyl starches, but in an and this was like the patient were out of increases which are septic patients as compared to non-septic surgical or trauma patients. Now there is an evidence in favor of starches as well. So it is not like it is just like the evidence against starches. There is evidence in favor of starches as well. May I request somebody has a mic open so that it can turn off your mic? Okay, so this was one of the study which was meta-analysis and systemic review published in 2016. They compared the starches with the crystalloid for surgical patients. And they reviewed found that no statistically significant difference between the starches and crystalloid in terms of mortality. But they also mentioned in their systematic review that eligible trials were too small to draw firm conclusion on this issue. Then there was a flash trial. They compared this starches with saline for volume replacement, and this was done in under major abdominal surgery. And they said that there was no significant difference in a composite outcome of death or major postoperative complications within 14 days after surgery. There was also a RCT done in like in 2020 in Cham. So this was another recently published article in anesthesia and analgesia with a meta-analysis, and it was starches in a patient undergoing major surgery. It also said that this was abdominal were not associated with or major adverse kidney events after 30 days post-op. So newer studies used third generation hydroxyethyl starches with a low molecular size such as 6% or 10% as well. And most of these studies compared starches with saline. However, the results of analysis, despite showing no of positive, suggest that use of hydroxyethyl starches associated with a higher red blood cell transfusion rates as well. So on this busy slide, you will be seeing like three large studies. The first one was hydroxyethyl starches versus ringer acetate. So this study was published in New England Journal of Medicine. Uh, it showed that the patients who were resuscitated with starches as compared to ringer acetate were having high mortality, high renal replacement therapy, and higher blood transfusion. So it clearly favors the ringer acetate as compared to hydroxyethyl starches in severe sepsis patient. Then there was a study in 2013 by Crystal randomized control trial. This study showed that there's no difference in the mortality if the patients are resuscitated with starches or with the balance or saline solutions. The last study, which is like hydroxyl starches or saline for fluid resuscitation in intensive care. This was published in 2012. It also showed that there is no difference in mortality, but there was increased risk of renal replacement therapy. So still we are like saying there are studies in favor of hydroxyethyl starches versus the crystalloids or balanced salt solutions. So what about gelatins? In Pakistan, we usually have these gelatins. We don't have starches. The data on gelatins is very limited because these were banned in USA by FDA in 1978, and not the same bulk of evidence is available like starches. And the molecular weight is 3 kilodalton, which is below the renal threshold. The volume effect and the duration of volume expansion are less compared to starches, but almost the effect is the same. Available literature suggests that they have shorter duration of action, less nephrotoxic, affects coagulation and increased risk of bleeding, a relatively high incidence of anaphylaxis. The interesting thing is that previously the gelatins were formed by the urea-linked gelatin, and that urea-linked gelatin was associated with increased risk of anaphylaxis, and they affect the coagulation as well. But now the new ones are modified fluid gelatins. They are like having a very low incidence of anaphylaxis, and they have a less effect on coagulation as well. So we don't see very often the allergic reactions with these gelatins. Same Cochrane study in 2018, which I already described with the starches, it also shows that there is very low certainty evidence for increased risk of blood transfusion with gelatins as compared to crystalloids, and data for renal replacement therapy were also not reported separately for gelatins. So till now we were like confused. Now this was one of the systematic review and meta-analysis which is published recently in 2022, and which showed that it included almost like 55 RCTs, more than 27,000 patients. It's a very like extensive one. It showed that the 90-day mortality was significantly lower for crystalloid compared with starches, and crystalloids were less efficient than colloids at stabilizing resuscitation endpoints. So guidance on to which switch is urgently required. So the meaning was that like when to switch from crystalloid to colloid, we don't know, but like 90-day mortality was significantly lower for crystalloid as compared to with starches. So they propose that we should have some endpoints with the, like we say that now we have given sufficient crystalloid and now we switch to colloid, but still it's undefined. So at what point we need to shift from crystalloid to colloids? So some arguments by the proponents of synthetic colloids. First, maybe inappropriate hemodynamics causes the kidney injury and not synthetic colloid. So might be the patient was like really hypotensive and like and patient was in a septic shock, having a high Apache score. That was the reason for kidney injury, not the synthetic colloid. In addition, hypovolemia and fluid overload are both associated with organ failures, as we already or we know. Some arguments by the proponents of synthetic colloids, like second, the dose of interference fluids has an important impact on the outcome. So either we don't know how much like the colloid have been, either it's given like 2 liters, 1 liter, 1.5 liter, or 500 ml, we don't know. A certain volume may be safely used without increasing renal related outcome. So as like we know that if we increase the dose of a drug, we have the increased side effect. So if a patient receives more of a colloid, then there's a more chance of renal injury. So we can use a safe amount of colloid without harming the kidney, but we don't know what is the safe amount. Finally, in several studies, renal replacement therapy is often used an outcome parameter, but the initiation of this therapy is not standardized, making this a weak endpoint. So we don't know in these studies at what point they have started the renal replacement therapy. As we all know, as a physician, there is always an argument between the intensivist and the nephrologist when to start the renal replacement therapy. Some are like starting early, some are starting late, so we don't know. So this is one of the things that makes the difference in the outcomes of the patients as well. So in the closing remarks, that bulk of evidence says they are more harmful. Some evidence says they are equally harmful. No evidence seemed to support synthetic colloid superiority over crystalloids regarding patient safety. As I already told you, that gelatins were withdrawn from the US market in 1978 due to the concern of increased blood viscosity and coagulation impairment. FDA and also the European Medicines Agency issued multiple warnings against. In 2021, the FDA required additional warnings about the risk of death, bleeding, and AKI for starches. So, like the FDA in the America as well as the European Medicine Agency have directed the companies which are making the starches that they should incorporate the leaflet in with the bottles that this starches can cause has the risk of increased death, bleeding, and AKI. And like there is a debate going on that starches should be banned in the Europe as well immediately. But some of the physicians are against it because like most of the data which is coming for these starches is in these septic patients in ICU. So they are saying that in a sepsis, this starches should not be used or gelatins should not be used. While these can be used intraoperatively as the glycocalyx, like the endothelium, is not damaged in these surgical patients where there is an acute volume loss or blood loss. So we can use these starches intraoperatively, but these starches or gelatins or colloids, you call it, it should not be used in an ICU for particularly for sepsis patient, burn patient, or the pancreatitis patient, the most common patient which we see in ICU. But in like intraoperative, if there is a blood loss or volume loss, we can use these starches. So most probably from the market, like from Europe and from America, these starches might be like limited to intraoperative use, not for an ICU use. Until FDA and European warnings are withdrawn, there is a very weak medical legal justification for using synthetic colloids. So if we use synthetic colloids in an ICU for a sepsis, burn, or pancreatitis, and patient, God forbid, like had a complication with the fluid overload or something like that. So with FDA and European warning, it become a little bit difficult to defend yourself. Now we come to the albumin. Human albumin is pasteurized and does not transmit any known infectious disease. Albumin is available in both 5 and 25% solutions. 5% has a volume effect. And as we all know, albumin is very expensive. This is a slide which is showing like an evidence from an albumin. Like the first part is showing the harm or no evidence. Like we cannot use the albumin for extraperitoneal infections. It has some role in the spontaneous bacterial peritonitis, but not extraperitoneal infections. We should not use this albumin in acute traumatic brain injury patients. This was already have been a data published in a SAFE trial, which is a big trial, which showed that the patient who were resuscitated with a traumatic brain injury received albumin would have a worse outcome. The possible reason was that due to ruptured blood-brain barrier in traumatic brain injury patients and albumin and causing the ICU. The possible role, but certain is in sepsis, diuretic resistance, or cardiac surgery. Recommended use is in sepsis resuscitation after large volume of crystalloid. As we all know, the Society of Critical Care Medicine says that if you have given enough amount of crystalloid to the patient, like 30 ml per kg, and then you see that the patient is still hypotensive, then you can use the albumin. Hepatorenal syndrome, it definitely has a role, large volume parasitosis or ultrafiltration in patient with hypoalbuminemia. So these are the indications which are recommended to use albumin, but these are possible role, but evidence limited or uncertain, and the harm or no evidence is like the extraperitoneal infections. This was one of the largest study, the Albios trial, which was published in New England Journal of Medicine in 2014. And in this study as well, there was not the first time in the first results, it was a post hoc analysis of the patient with septic shock, which showed a lower risk of death when they use this albumin for resuscitation. But there was no difference was observed either in mortality or overall organ failure at 90 days. But after like they done a post hoc analysis, it showed that in septic shock patient, there was a lower risk of death when they use an albumin. Lack of evidence in favor of albumin. This was like Cochrane, the same Cochrane review, which I already mentioned, which was published in 2018, which showed that little or no difference to the need for renal replacement therapy in a patient if we use albumin for resuscitation. There are two large trials ongoing on an albumin Italian outcome septic shock balance trial, and the other is albumin replacement therapy in septic shock. So hopefully once these two trials, the results of these two trials might change our practice in giving the albumin to the patient. So let's see, wait for the results of these, and these are ongoing trials. I mentioned there, and so let's see once their results are out, then what is outcome. So with an albumin, it's very expensive. It's almost cost in Pakistan around like 14,000 rupees. The significant cost and lack of concrete evidence till today do not play in favor of albumin as a peri-op fluid, especially for low middle income countries or like an ICU as well. So Overall literature favor the use of crystalloids over colloids due to increased safety profile and being cheap and easily available. Now, the next big question is which crystalloid? Balanced crystalloid like ringer lactate versus normal. I usually call it as an abnormal saline. So these are the available intravenous fluids we have. And interestingly, I have mentioned this ringer lactate, ringer acetate. This is D1% in balanced solution. We don't have this. We have this in Pakistan as well, D5% dextrosaline. We don't have plasmalite, but we have saline, we have sterofundin. And if you see, this is the like the plasma concentration of the different electrolytes, the dextrose, the in vitro. This is the like strong iron difference which I was talking about. So the ringer lactate strong iron difference is 28 and our plasma is 40. So it's almost like near to it. So we can use it. The strong iron difference of sodium, this 0.9% saline is 0. So this is like acidic. It is interesting, like the pH of saline is also like 5.5 and ringer lactate is 6.5. So if you give saline to someone, there's like more chances of acid-base disturbances as compared to ringer lactate. And the osmolarity is almost the same. So these are the isotonic, isoosmotic fluids which are available for resuscitation. So clinical evidence of 0.9% saline versus balanced solutions. So we will see in a couple of slides the randomized control trials. So the first trial was in 2018, which was called a SMART trial with balanced crystalloids versus saline in critically ill adults. There was a small difference in the incidence of major adverse kidney events within 30 days, and which is like death, renal replacement, or persistent renal dysfunction in the favor of balanced solutions. So it was clearly like supporting the balanced crystalloids. Then there was a salted trial in 2018, which also compared the balanced crystalloid versus saline in non-critically ill adults. It also showed that balanced crystalloid resulted in a lower incidence of major adverse kidney events within 30 days than saline. Now we move to the trials which say that there is no difference between giving the balanced solution versus saline. This is one of the trial known as BASICS randomized clinical trial, which was published in 2021, I think so. So it was a balanced solution compared with 0.9% saline solution did not significantly reduce 90-day mortality. And this finding do not support the use of these balanced solutions. Then there was a split randomized control trial, a famous trial that also say that use of a buffered crystalloid compared with saline did not reduce the risk of AKI. Then we move forward. This is called a PLUS trial. This is published in 2022. It's also a big trial. And they also said we found no evidence that the risk of death or acute kidney injury among critically ill adults in ICU was lower with the use of balanced electrolytes than with the saline. So we are confused either which trials are better and which either we should choose a saline or not. So there was like a large systemic review meta-analysis which was published in New England Journal of Medicine, a reputed journal in 2022 in January, and which shows that the estimated effect of balanced crystalloid versus saline in critically ill adult ranges from a 9% relative reduction in the risk of death with a high probability that the average effect of using balanced crystalloid is to reduce mortality. So this meta-analysis clearly, systematic review clearly favors that we should use balanced crystalloid as compared to just saline because it increases the risk of AKI and mortality as well. This is one of the old randomized control trial which show the possible adverse consequences of large volume saline administration metabolically causing hyperchloremic metabolic acidosis, kidney, it causes acute kidney injury. It also affects the vasopressor requirement as well, possibly hematologically coagulopathy, increased blood loss. But these are all the effects. But we know for sure that it causes the acid-base disturbances, pH alteration, which can lead to the hyperchloremic metabolic acidosis, other problems as well. Couple of words for the hypertonic crystalloids. These are like, I also again highlighted the dextrose. These are all the available consultation we have in Pakistan as well. So they are mainly used as maintenance fluids, and they are usually used as a treatment of hypernatremia, but they are not used for resuscitation purposes. Hypertonic crystalloids, we usually have hypertonic saline. Available consultation are 3, 5, 7, 23. We usually use 3% all over the world. I search like a lot of literature on that as well, but nobody has used this for resuscitation until unless patient have a severe symptomatic hyponatremia to keep the sodium around like 120. And a bolus of like 100 to 150 ml of hypertonic saline can be given to correct severe symptomatic hyponatremia, which I've already told you, but not people have used it as a resuscitation fluids. Now, couple of slides for restrictive or liberal fluid management. So there are a couple of studies which have recently come out, like in a patient, like either we should use a restrictive or a liberal fluid management for sepsis-induced hypotension. So the restrictive fluid strategy that was used in this trial did not result in a significantly lower mortality before discharge home by day 90. So they clearly say that either we should use a restrictive or liberal fluid management for sepsis-induced hypertension. It doesn't make any effect. This is the trial, recent published article, restriction of intravenous fluids in ICU patient with septic shock, published in like 2022. It also showed that did not result a significant difference in the mortality when we use a standard versus the like the liberal one or a restrictive one. This is a slide which showing the fluid overload. We all know, like I want to mention this because like restrictive versus liberal, but we all know that if the patient have a more cumulative fluid balance, which I've already like mentioned in my second slide, if more than 10% of a fluid overload with a cumulative fluid balance of more than 10%, then the patient will have complications. And there are like a lot of complications we all know. No need to discuss with that at this forum, but like we all know that, so we should avoid the fluid overload in our ICU or critically ill admitted patients. So a couple of last 3-4 slides. The 4 indications of fluid therapy. So number 1 are resuscitation fluids. So we say that colloids in an ICU don't have any place right now, according to the recent literature. So it is the crystalloids, and in the crystalloid, it's the balanced crystalloids. So that should be used in the ICU for resuscitation of the patients. Then these are the maintenance fluids. I have already mentioned these are the hypertonic fluids, which we use for like the maintenance. By maintenance, I mean that we know that how much fluid we need per day. It's like around 20 to 25 ml per kg per day, or some people use that like 1 ml per kg per hour. We need a potassium of 1 milliequivalent per kg per day. We need a sodium of 1 to 1.6. We need a dextrose of 5 to like 1.4 to 1.6 gram per kg per day to limit the starvation ketosis. So these are the maintenance fluids. So we can use hypertonic fluids for maintenance. Then there are replacement fluids. Either we know what we are losing. So if a patient is having a lot of vomiting, so the patient might need a saline to replace our chloride. So the fluid we are losing, we should replace the body with the same fluid which we lose from the drains or from the vomiting or some other parts. The nutrition fluids. So we should calculate what amount of water they are using in a TPN. We cannot use separately the TPN and then the maintenance fluid. So we need to calculate how much fluid we are giving during a 24-hour periods. As I already told, that normal requirement is around like 20 to 25 ml per kg. So we don't want to like make our patient fluid overload. So we need to calculate what amount of fluid is given in TPN, in what form, in dextrose, and what the volume we are using in a 24 hours period. This is like intravenous fluid therapy in the perioperative and critical care settings. This is an executive summary of the International Fluid Academy. I will strongly recommend you, either you should read that book, The Rational Use of Intravenous Fluid in Critically Ill Patients, or like go to the website to International Fluid Academy it's like there are no charges. You can become a member. You can have a free access of online material as well on the fluids as well. So they usually talk about the fluids only. So they explain this in their executive summary that the 4 Ds of fluid management: drug, dosing, duration, and de-escalation. So they say that fluids are drugs and they should be an indication, there should be a contraindication, and like all the other drugs, these fluids have a side effects as well. So every person who is prescribing the fluid should consider them as drug. So we should have a clear indication why we are giving it. Either we are giving as a resuscitation, either we giving as a maintenance, either we are giving as a replacement, or either we are giving a nutrition. And what are the contraindications? Why we cannot give this patient a like saline, or either this patient I should not give an albumin, or either we should not give this patient a colloid. So we know that. And what are the side effects of fluid? Dosing. The dose makes the poison. So if we use the excessive amount of like a simple paracetamol, we can get the patient hepatic failure. So timing and administration rates are equally important for the fluids. In contrast to most drugs, there is no standard therapeutic dose for fluids. As is unfortunate, we do not consider this. Like if we know that if we give more than 4 grams of paracetamol per day, we can land the patient in a trouble with like hepatic failure, acute hepatic failure. But with the fluid, if we give a 4 liter, we are happy. It's okay. There's no problem. We can just wait and see how it getting side effects and everything. So there is no upper dosing of this the fluids. Duration. The duration of fluid therapy is crucial, and volume must be tapered when shock is resolved. It is interesting that there is always triggers to start the fluid resuscitation, but there is like we have no stopping triggers of fluid resuscitation. So clearly, we should develop these triggers that if the patient is not now volume responsive, we should stop giving the fluids. I don't go into the detail of how we should do the volume responsiveness, everything, but once what if we are giving a fluid challenge and patient is not like responding, what are our titration endpoints, which we have already seen that either the heart rate, the blood pressure, the urine output, or so then we should stop giving the fluids. So there should be our stopping triggers as well. De-escalation. The final step is the fluid removal. Once the patient do not remove the fluid, we should start de-escalation. Interestingly, these are the 4 phases, which is called as a ROSE concept, and this is by also as International Fluid Academy. So they say that the first phase is resuscitation phase. Life-saving, it should be like patient should be given an adequate amount of fluid, and it should be like according to the Society of Critical Care Medicine, it should be 30 ml per kg per hour. But you know that in the first hour, it should be given 30 ml per kg in the first hour of the patient presenting with a septic shock. But it's also best practice statement. We don't know that patient needs that 30 ml per kg. So the other proponent says that we should give a fluid challenge bolus of 4 ml per kg given in 5 to 10 minutes and see what's the response. And then we give this fluid challenge repeatedly and see until the patient stop responding. And then that is the endpoint. Then there's an optimization phase with a focus on organ rescue that maintains and avoiding fluid overload, aiming for a neutral fluid balance. Once patient is resuscitated, not optimize the organs rescues, maintenance, and avoiding fluid overload. Then the stabilization phase, with S stand for stabilization, with focus that we should now define as a late conservative fluid management, which is defined as 2 consecutive negative fluid balance within first week. Like fluid balance, patient came with a septic shock, you have resuscitated, now it's the 4th, 5th day. Now you see that you maintain the fluid management of the patient like that. It should be the patient should have a 2 consecutive negative fluid balances within first week. Like it should be 2 days with a negative fluid balance. And then last is the evacuation phase with a focus on organ recovery and resolving fluid overload with active late goal directed fluid removal and negative fluid balance. Then you start giving diuretics or anything like that, so that patient should be, the excessive fluid should be evacuated, and we should like have not the effect of the fluid overload. In conclusion, fluid administration has to be considered a pharmacological intervention. You don't like give it give this patient a 1 liter of fluid, give this patient a 1500, start maintenance at 120, start giving 150 ml per hour. So either it should be rationalized. Colloid administration should be considered rescue therapy and remain limited to profound active hypovolemia. As I already told you that colloids are banned in, like now they are having banned from the Europe as well as from the FDA warning from the America as well. Their role might be now limited to the intraoperative phase until unless there are large like studies. God knows, like in 3-4 years again we are switching to colloids back. But like for now, they are not for a patient with sepsis, burns, or pancreatitis and for resuscitation in ICU. There is a sizable body of observation, intervention, and prospective clinical trial data that suggests that there is a clinically important factor of choice of crystalloid fluid on outcomes in adult ICU patient. So balanced crystalloids should be used. Balanced are those which have a strong ion difference close to the body plasma, or which the solutions which have a low chloride content. The use of 0.9% saline may still have a limited role in resuscitating patient with possible raised intracranial pressure. So we already know that in traumatic brain injury, we use the isotonic fluids. In replacing gastric fluid losses, as I already told, they're vomiting as a direct diluent where when 5% dextrose is contraindicated, or when no other isotonic crystalloid is available for resuscitation. With the exception of those with a traumatic brain injury or pronounced hypochloremia, who should receive 0.9% saline. ICU patients should receive a buffered crystalloid fluid for initial and subsequent IV fluid therapy. So I end with this.
Thank you,
Slide.
Sohaib. Thanks for this wonderful talk supported by a lot of available evidences. So with this, we'll move towards the question answer session. We have a couple of questions asked by Dr. Mazdam Ali Shah. His first question is there any absolute indication of crystalloid infusion, or is there any absolute indication of colloid infusion? His second question is, can we use balanced solution instead of normal saline in ICU? We can't hear you. Unmute your microphone, Sohaib.
Sorry, sir. So the last question, the evidence says that we should use a balanced solutions in comparison to saline for resuscitation in ICU. Number one. So the literature right now favors this. The other one is like what was the first question, that what was the absolute indication of
is there any condition where we can give only the colloid or only the crystalloid?
No. So I have already told that there is no absolute indication of giving a colloid. Okay, so like if we know that that's why they say that you should give a fluid challenge, and to see that the people have defined fluid challenge like with the saline, with balanced crystalloid, with colloid as well, mini challenge. The problem lies when the patient is having a right ventricular failure. So the problem is that we don't want to overload the patient. So once we give this fluid challenge and see the response, if the patient doesn't respond to fluid challenge, the cardiac output is not increased or the stroke volume is not increased, then we should not give the colloid or crystalloid. So these are the absolute contraindication. If patient not volume responsive, you should not give the fluid. But if like there is no absolute indication of giving a colloid, like I will give this gelatin to this patient, I will not give a balanced crystalloid. So as the evidence says that colloids are harmful, so either we should avoid them. It's better to give the balanced crystalloids.
Okay, thank you. There is a question by Dr. Shabir Jomani. Can we give blood products such as FFPs, etc., for fluid resuscitation?
So there is no like controversy giving the blood products or FFPs as a replacement fluids. Like if the patient is losing the blood loss, if he's having a hemorrhagic shock, we all know that the hemorrhagic resuscitation is like 1:1:1. So that volume should be replaced by blood, because by giving a lot of crystalloid, we will be landing in a problem. either it should be a balance or either it's a saline. So both the volume over resuscitation will be bad in a patient if the patient is in a hemorrhagic shock or patient is losing volume. So we can give blood products, but like giving these FFPs, we already know that these are like plasma containing products and they are always having a side effect. But to increase the oncotic pressure, like we want to increase the oncotic, we give the FFPs, we don't use this practice. If these FFPs are indicated, we should give them. If these are platelets, we should give them, but they cannot replace the fluids like for the resuscitation.
Okay, thank you. There is another question by Dr. Asma Salam. Utilization and or limitation of sterofundin in severe hypovolemia.
Yeah, so when I mentioned my slide for that the available intravenous fluid, so we have a sterofundin in the last. The problem with sterofundin is that this sterofundin has a high chloride content, so that it's around like 127. So it's not come into the balanced one, but its strong iron difference SIDS is around like plasma. So this solution doesn't cause major shift in like acid base balances. So that can be used as a resuscitation fluid in hypovolemia. So it's still considered as a balanced one due to strong iron difference, but due to high chloride content, the problem with the hyperchloremia is like it causes the increased kidney injury. That's why it was fell out of favor in like a lot of ICUs, but still people are using it as a balance due to its strong iron difference and osmolarity, and they consider it as a balanced solution. So we can use this steroid.
Okay, so what you will suggest, what should we use fluid of choice in our setup and in public setup where we have limitation of money as well?
So look, so clearly there is no strong evidence to use albumin, number one. We don't still there are two large trials going on in a patient for septic shock and in perioperative settings as well. So we don't know that either albumin is helpful. So in Pakistan, I think so we cannot use albumin as a resuscitation fluid and as a perioperative. Second, in like we have this hemexil and we have this gelatin as a colloid. In perioperative setting, there is a clearly low if the patient is having a loss of volume in terms of like hemorrhage, and we are waiting for a blood, or patient is like hypovolemic due to any other reason like drain output is more, and patient is not in sepsis. I am again mentioning patient is not in sepsis or having a pancreatitis, so we can use colloids in that patients. Rest all of the patients, we have this balanced salt solution. This is ringer lactate. This is the only one we have available having this isotonic or isoosmotic fluid. So we should for resuscitation that be the balanced crystallite solution. For maintenance fluids, we all know that we have to provide some kind of dextrose, we have to provide some kind of saline, we have to provide some kind of sodium and potassium. So we can use these half-strength dextrosaline solutions for maintenance one. And replacement fluids, if we need a replacement with the fluid, like if we are losing from a drain or something, the ringer lactate is the answer. If we are losing from a vomiting point of view, hypochloremia, saline is the answer. So clearly, in Pakistan, we have this ringer lactate that is the most osmotic fluid or isotonic fluid, which is like comparable to plasma, so that we can use this fluid in our setups.
Thank you, Sohaib. Okay, you have mentioned a lot of fluid trials that have been done outside the Pakistan, the first world country. I'm surprised why we are unable to conduct any trial in our population, in our setup, in our hospitals. What is the reason as an intensive care physician? What is your take on this?
Sir, actually, in our setup, the problem is that there is like a wide variation in the practice of fluid. So for to conduct a trial, like a very stringent one, so we need to start from an ER or a perioperative phase. As a physician, we know all that. And like in these trial, but there are like so many factors which are affecting. Like I tell you that this is the trial which showed that split trial. The people said that the saline and the balanced solution make no difference. The critique on that trial was that the volume given to the patient was only 2 liters, in the theater. We don't know the amount of the resuscitation fluid given other than that to the patient. So these are the problems which are for a very for like a good outcome, we need a very stringent criteria for that. I think so we can do that, because like for gelatins there is very much less data overall due to it was banned by FDA in America in 1978. After that, Americans never use that. So that's why they are like the leaders in the research. So they have never used the gelatins again. But in Europe, the gelatins are used, but like now they have also issued a warning. So gelatin, they have also off the label the bar. We can use on our population and see that what are the outcomes in an ICU patient, and see either there was an increased risk or anything like that. But like there are so many confounding factors with high Apache score. There are multiple comorbids and everything, different practices before coming to the hospital. In the ER, there's a different. So that is I think so the main problem is this. So like as a group, we can do that, like in a different hospital settings, in a private and public sector, and combine, and then can see the outcomes.
Thank you. So we have ex-president of PSA Karachi with us, who was enjoying salad throughout the presentation. So I would request Dr. Shabir Jamani, please have some concluding remarks and have few words with us. Dr. Shabir.
Thank you very much, Dr. Rahman. Thank you very much, Dr. Sohaib, for presenting such a beautiful lecture. It was an excellent presentation, and time management was excellent. The answer to the questions were up to the mark, I just suggested, as Dr. Rahman said, and I was thinking of that, I was just typing this thing, that there's a lack of study in our country. So can we set up a combined multi-centered local study on this very important topic? It can be supervised by PSA Karachi chapter as well, I think so. Anyway, thank you very much. And
it's a nice suggestion. You can look into this offer, as you are already engaged in a number of studies and grants. So if there is no any other question, we can stop here. And thanks once again, Dr. Say, for sparing your precious time and for enlightening us regarding the fluid management. Thank you, Sohaib.
Thank you, sir. Thank you so much for giving me an opportunity for this talk. Thank you, sir.